Hey folks, Weingart here. This is the lecture I promised you. This is a lecture by my friend Chad Meyers, an ED intensivist currently working in New York City. This was actually a lecture given at one of our conferences at All New York City. It was amazing, and unfortunately the quality of the video recording at that point was pretty crappy. And so I asked Chad to re-record it, and that's what you're going to see now. This is actually the lecture that gave me the words fluid tolerance, which is such a huge concept. I've been describing it as safe to give fluids, it's okay to give fluids, but Chad just encompassed that whole idea into two words, fluid tolerance, that makes it immediately understandable and a justification to use modalities like IVC ultrasound. He also gives you a very nice approach to ED fluid management, the concept that we're not going for the holy grail, as he calls it, of fluid responsiveness, where we could be satisfied with just making sure we're not doing harm in the ED, and after the first 24 hours, folks could actually go further and actually start using fluid responsiveness. It was from this lecture that my whole concept of the bronze, silver, and gold medal came out, so it's a great talk. And enough crap, let's get right to it.
My name is Chad Meyers. I'm an attending emergency physician at Bellevue and NYU. I also have a background in critical care. I completed a critical care fellowship. And I've had a long-standing interest in hemodynamic monitoring, in particular, the determination of fluid responsiveness in septic patients. Well, unfortunately, methods to determine fluid responsiveness, especially in the spontaneously breathing population, typically proven to be cumbersome and time-consuming. And to be totally honest, I've struggled for a long time in terms of coming up with a realistic approach that could be applied in the emergency department to a large number of patients. Now, the problem with the literature regarding fluid responsiveness is that it almost all comes from the ICU, and therefore it typically requires us to think about our patients like they're already in the ICU, which of course they aren't. And then I came across this study by Daniel Lichtenstein on lung ultrasound, in which he mentioned the term fluid tolerance, and everything sort of clicked into place for me. So what I have today is a proposal for a practical, completely non-invasive approach in terms of optimizing fluids in severe sepsis, utilizing the concept of fluid tolerance. I'm going to start with a hypothetical case that we're all familiar with. So an elderly patient's brought in by her family, history of a few days of decreased PO, lethargy, weakness, and difficulty breathing, the cough productive of sputum. Hook her up to a monitor and she's tachycardic, a little hypoxemic, but her blood pressure looks normal. You suspect pneumonia, so you treat her appropriately, and you culture and get some basic labs. Labs start coming back, lactate's a little elevated, white count's okay. Don't have a baseline, but her creatinine's a little elevated, so you place a Foley and you get 20 cc's of urine out. So the question is, what's next? Now, I think most of us would consider giving this patient fluid. Some of us give her a lot of fluid. However, you could also make the argument that this is a patient whose respiratory status is already marginal. You have no idea what her underlying cardiac function is. She may or may not have acute renal failure. And this is a patient that even a little fluid could potentially put this patient over the edge in terms of volume overload and precipitate respiratory failure. So how are we going to make the decision, or how do you make the decision in terms of how much volume that you're going to give this patient in terms of the resuscitation? Now, if you were to follow the guidelines of early goal-directed therapy, that involved putting in a central line and giving 250 cc aliquots of crystalloid or colloid until you achieve a CVP of between 8 and 12. But we know that one of the major perceived barriers to implementation of early goal-directed therapy is a requirement of central venous cannulation. And even more so, we also know that in patients that don't meet criteria for early goal-directed therapy or severe sepsis by shock, in patients that don't need pressors, we know these patients that meet criteria only by lactates, there's a significantly decreased adherence to early goal-directed therapy in this patient population when you compare it to the patients that need a central line because of pressor therapy. And the reluctance to place a central line for the sole purpose of monitoring, in a lot of ways, is a valid concern in terms of potential mechanical and infectious complications of central line placement, not to mention the amount of time it actually takes to place a central line when you're using maximum precautions in terms of sterility. Now, the proponents of invasive monitoring and early goal-directed therapy is that it gives you a sense of not only filling pressures, but also of global perfusion in terms of continuous or intermittent monitoring of central venous O2 saturations. But when we look at the data from the Lactate Clearance study by Jones and Shapiro, and arguably a patient population that was less sick than that studied by Rivers, what we saw was that very few of their patients actually met criteria in terms of prompts for inotrope infusion or the transfusion of red blood cells. In fact, most of their patients actually improved with just saline and antibiotics alone. Now, the best evidence in terms of the management of these patients is still by early goal-directed therapy, which includes placing a central line and monitoring them invasively. However, in reality, in our patients that aren't hemodynamically unstable, that don't need pressors, most of us are not putting a central line in. And I'm going to argue may lead to the under-resuscitation of these patients. So in terms of a fluid strategy, you get two main options. Either empirically load them, or you do it in some sort of guided fashion. When we look at early goal-directed therapy, in the experimental group that was guided by CVPs, these patients on average got about 5 liters and anywhere up to 8 liters of fluid. This is compared to the control group, who was guided empirically or administered fluid empirically. These patients on average got about 3.5 liters of fluid. Now, in a young patient without any medical comorbidities, it's easy to give this patient anywhere between 6 and 7 liters empirically. However, in our patient, I think even the most aggressive physician out there would be more than a little reluctant to give that sort of volume to these patients. So how do we manage these patients? And what I advocate is using a guided fluid resuscitative pathway, which brings us to the discussion of fluid responsiveness. So what is fluid responsiveness? So fluid responsiveness is the concept if I give IV fluid to a patient, am I going to see an increase in cardiac output? This is the same relationship that's depicted by the Frank-Starling curve, that for any increase in preload, I see a corresponding increase in stroke volume up to a certain point at which the curve plateaus, then I no longer see benefit. And the reason why this is important is I'm trying to resolve the so-called supply-dependent phase of oxygen consumption by improving cardiac output, and therefore restoring tissue perfusion. Now, historically, the most common method in terms of judging preload states is probably with the CVP, potentially pulmonary artery occlusion pressures. But the question is, does CVP reflect fluid responsiveness? And what was summarized by a systematic review of Paul Merritt, looking at CVPs in the ICU, is that CVP is no more likely than the flip of a coin to actually predict fluid response. So why is it in our unresuscitated patients in the emergency department, when we guide therapy using CVP bundled along with the rest of our early goal-directed therapy, why is it that we not only see improved outcomes, but we also see patients receiving larger total volumes of fluid without the consequence of increased need for mechanical ventilation? We take those same patients and we put them in the ICU, and all of a sudden CVP is useless? Well, in my opinion, what I think CVP demonstrates is the difference between the concepts of fluid responsiveness and fluid tolerance. Now, while fluid responsiveness is possibly the holy grail of quantitative endpoints to guide fluid resuscitation in all clinical settings, in the emergency department, specifically in the early aspects of the resuscitation, it's probably also unnecessary. And this is important because, especially in the spontaneously breathing patient, determination of fluid responsiveness has proven to be extremely difficult. Now, fluid tolerance, on the other end, well, might not be able to identify where the patient is on the Frank-Starling curve. Instead, assumes that in your unresuscitated patient who's septic, if as long as they're not fluid overloaded, they're probably going to benefit from fluid. And the reason why this is appropriate is that you have an elderly uroseptic patient that comes in the emergency department, they haven't eaten for 2 days. So even if they do have a degree of cardiac dysfunction, this patient is probably also going to be fluid tolerant. Now, there are a number of methods that you can determine fluid tolerance, but what I advocate is a rapid 3-step ultrasound survey that I call the Resus exam. Now, the strength of this procedure is that it's fairly quick once you're familiar with it. You can perform it, I at least perform it as soon as the patient is immediately upon arrival. And then I can repeat the exam throughout the patient's emergency department stay as needed whenever I see any sort of change in clinical status or evidence of volume overload. And I start with determination of respiratory variation of the Vena Cava. So on a standard subxiphoid view, looking at the component of the IVC just proximal to the hepatic veins, as the patient breathes in, you see a decrease in intrathoracic pressure, the diaphragm moves down, and we see a corresponding increase in intra-abdominal pressure. So if we're in a state where the patient has low venous return and therefore high right atrial compliance and also high IVC compliance, we'll see a complete collapse of the IVC. This corresponds with a patient who's going to be fluid tolerant. Now, the other useful piece of information from this, if you see a patient with complete collapse, is there's a good chance that they're approaching the so-called critical pressure, which right atrial approximates atmospheric pressure. And this is the point at which cardiac output is actually uncoupled from venous return. Now, the reason why this is important is because if this patient has a low cardiac output, poor contractility, you put this patient on a ventilator, you switch them to positive pressure ventilation, you're going to drop their cardiac output. There's a good chance you're going to have a code on your hands. Now, in terms of comparisons with static estimates of right atrial pressure, it's fairly good evidence to support that greater than 50% collapse of the IVC correlates well with a CVP of less than 8. Now, conversely, if we have a patient with adequate venous return and high right atrial pressures, we're going to see a static, unmoving IVC. Now, while this patient still may be volume responsive, I would at least approach this patient a little bit more cautiously in terms of administering volume to this patient. Now, one of the limitations of IVC evaluation is a failure to obtain measurements in a fair number of patients. So I supplement my IVC evaluation with a lung ultrasound. This is an abbreviated exam, concentrating on the apical 3 interspaces on both sides of the lung. Now, in a normal lung, what we see is typical lung slide along with this characteristic ring down artifact known as A-line predominance. Now, this is in contrast with a patient with pulmonary edema where we see these hyperintense comet tails or lung rockets known as B-line predominance. And what Lichtenstein demonstrated in the ICU and later described as an indicator of fluid tolerance, introducing the term, was that less than 3 B lines per interspace correlated well with low pulmonary artery occlusion pressures. And the last component of the survey is a quick qualitative assessment of the patient's left ventricular systolic function. And you can get a lot of information out of this exam. The patient comes in and they're hyperdynamic. This is obviously a patient that's going to be able to tolerate fluid a lot better than a patient who comes in with a severely hypokinetic left ventricle. Furthermore, in an abstract that was presented at the Society of Critical Care Medicine Congress just last month, demonstrated that early standardized echo in the ICU, if it was performed within 36 hours of the patient's arrival, the patients who had their therapy guided by that echo ended up having not only improved survival, they also had decreased days on pressors and decreased days on the vent. Now, the question of when to stop is a little bit more complicated, and definitely one of the weaknesses of indicators of fluid tolerance is the identification of the upper inflection point of the Frank-Starling curve. But these indicators can still give us a little bit of guidance. And if we use a different right atrial cutoff of greater than 10 millimeters of mercury, and we see that our sensitivity and specificity start approaching 100% when we get to about 30% collapse. So in reality and practicality, what I typically do is I give fluid until I see little to no collapse of the IVC. And hopefully, what I'm targeting is trying to give at least 4 to 5 liters to these patients before I stop, at least. And oftentimes, you'll still have collapse when you get to 4 or 5 liters, and then you can be justified in giving more. Now, the one caveat is lung ultrasound is a little bit too sensitive for these purposes. And you're going to see the appearance of B lines before the patient's actually volume overloaded. So you have to be cautious in terms of restricting your fluid just because you're identifying some B lines on the ultrasound. I'm not saying don't be cautious when you see their appearance, but I think they're not going to be useful for determining your endpoint. So we've given the patient fluid, and hopefully we've improved their cardiac output. The question remains, did we resolve the so-called supply-dependent phase of oxygen consumption? And are we now perfusing our tissue? Since we don't have a central line and we can't draw a central venous O2 saturation, instead, our second best indicator of global perfusion is going to be serum lactate. And what Jones and Shapiro demonstrated was that a lactate clearance of greater than 10% was roughly equivalent to using central venous O2 saturation as a guide therapy. Now, the one limitation, or potential limitation of this study, is that, as I mentioned before, the study population in the Jones trial was arguably quite a bit less sick than the population in the Rivers trial. Their lactates were around 4, or an experimental group actually less than 4, versus the Rivers trial, who on average had a lactate of anywhere between 7 and 8. So it's still in my mind the question of whether or not we can extend these sort of conclusions to our patients with much higher lactate levels is still there. And I think there's probably better evidence to support the utilization of normalization of lactate to guide our therapy in terms of reassurance that we're actually adequately restoring perfusion. So the final question is, can a patient that comes in that's identified as fluid intolerant and volume overloaded, can that patient still be fluid responsive? And the answer to that is yes. But unfortunately, this is a patient in which measures of fluid intolerance or fluid tolerance are going to fail you. But what they have done, what they have accomplished, is they've identified potentially the sickest patient that you've got in the emergency department. And definitely probably justify further advanced, potentially even invasive modalities of determining fluid responsiveness. So to summarize, start with a patient with severe sepsis and a moderately elevated lactate. Do a quick ultrasound survey. You identify the patient as being fluid tolerant. If you got a hyperdynamic echo, if you got IVC collapse and they have no B lines, you begin giving them fluid. You repeat your ultrasound exam every liter or two until you see little to no IVC collapse, or you see any evidence of pulmonary edema or volume overload. At this point, you repeat your lactate. If it's normalized, you can feel pretty good that you're at least heading in the right direction in terms of restoring adequate tissue perfusion. Now, on the other hand, you identify a patient as being fluid intolerant. And they have a hypokinetic echo, they have a static IVC, or they already have B lines. Well, this is a patient you're probably going to have to take your time and pursue more advanced modalities of determination of true fluid responsiveness. So for instance, you have a patient on a vent and calculate pulse pressure variation or brachial artery peak velocity variation. This patient spontaneously breathing and parapassive leg raise with some determinant of cardiac output. Now likewise, in your fluid tolerant group, you've already achieved your hemodynamic endpoints, or the patient's developed evidence of pulmonary edema, and you repeat your lactate in this patient and it remains elevated. Well, again, you're probably going to have to go back, take your time, and do a true measure of fluid responsiveness. So thanks for listening. Thank you, Scott, for giving me a chance to present this material. If you have any questions regarding fluid tolerance or fluid responsiveness or hemodynamic monitoring in general, feel free to email me. Thanks.